Hello, I'm Teresa Bird. I am one of the maternal co-chairs of the Georgia Perinatal Quality Collaborative. I'm also the Health Equity Liaison, and we're here today to talk about Heart Matters, Navigating Cardiovascular Disease in Pregnancy and Postpartum. First, we're going to start off with a case presentation. A 25-year-old obese African-American G2P2 presents to the ED 10 days after an uncomplicated vaginal delivery with fatigue and persistent cough since delivery. Blood pressure is 110/80, heart rate 110, respiratory rate 28. She's afebrile with an O2 sat of 94% on room air. She gets diagnosed with a respiratory infection and is prescribed an antibiotic. Fatigue is attributed to lack of sleep. 1 week later, she presents again with continued symptoms. Antibiotics are switched and beta agonists are added for presumptive new onset asthma. 2 days later, the patient experiences cardiac arrest at home and resuscitation attempts are unsuccessful. Autopsy findings were indicative of cardiomyopathy. Unfortunately, this case is similar to cases that we have known about all across the country. And specifically, I put here a picture of Dr. Shalon Irving, who was a PhD researcher here at the CDC in Atlanta, who died in 2017 under similar circumstances. And I want us to focus on the patients and realize that we really need to make sure that we are addressing cardiovascular disease in pregnancy and remembering the faces of the women that have already been affected, and hopefully personalizing this so that we can decrease the risk of this happening to women all over the country. I want you to ask yourself, have you cared for a pregnant patient or postpartum patient in the past year? I'm sure if you're watching this video, the answer is a resounding yes, right? We're here talking to family medicine providers because we know that you all also care for pregnant and postpartum patients and are integral in their care. But how would you feel if you knew the patient died of a cardiac event shortly after leaving your office, right? And how would you feel if you realized her death could have been prevented? And so that's the real essence of what we're talking about today. We're talking about cardiovascular disease in pregnancy and prevention and what we potentially can do. The objectives for today are to discuss the leading causes of maternal death and the time in which postpartum mothers have pregnancy-related risk, describing the signs and symptoms of cardiovascular disease during pregnancy and postpartum, reviewing the most severe cardiac conditions with the highest mortality risks, and understanding the importance of implementing cardiovascular disease risk assessment and the steps included in screening for cardiovascular disease risk. We're going to first start by discussing the leading causes of maternal death and the time in which postpartum mothers have pregnancy-related risk. First question, what is the most recent maternal mortality rate as of 2021 per 100,000 live births? Is it 17.4, 10.1, 23.8, or 32.9? The answer is 32.9. So here are the US maternal mortality rates here, 32.9 as of 2021. All of the other answers were the preceding years, realizing that the rates have continued to rise in the US. And maternal mortality by race and ethnicity shows us here that maternal mortality is 3 times higher for Black women than for our white and Hispanic counterparts. So really focusing on the fact that Black women have a much higher risk of dying in pregnancy and postpartum, and it's really important that we identify ways in which to get rid of the statistic. Another question, what is the leading cause of pregnancy-related deaths in Georgia? Is it hemorrhage, mental health conditions, cardiovascular disorders, embolism, or COVID-19? And the answer here, again, cardiovascular disorders. So we can see by this slide here, as of 2019 to 2021, all cardiovascular diseases together totaled the largest number of deaths in the state of Georgia, and which is why we're focusing on this today. And if you see here, the leading causes of death, cardiac conditions, COVID-19, again, the pregnancy-related deaths, 35.6, showing here that Black women had a rate of 58.7 compared to their counterparts, non-Hispanic white women at 24.2. And 85% of these deaths had some chance of being prevented. So again, this is why we're here and this is what we're talking about today. But the fact that 85% of these deaths were deemed preventable is something that we need to talk about and make sure we address. This slide really highlights the importance of the postpartum period and the need to pay attention to moms for up to 1 year postpartum. If you see here, 71% of the deaths occurred after delivery. And most of the deaths are clustered around that delivery to 60 days postpartum, and even up to 180 days. But you can see there are a few deaths, about 20%, that still lingered about 60 to 365 days postpartum. So that's why we still want to ensure that we are evaluating moms and identifying moms up to a year postpartum, and that's what we're here to talk about today. So really focusing on the 71% of patients who have deaths occurring after delivery is something that we want to highlight, and it's why we have you as family medicine providers here today. So next, we're going to talk about describing the signs and symptoms of cardiovascular disease during pregnancy and postpartum, so we can identify what we're talking about. So this is the what? Cardiovascular disease in obstetrics. So why is cardiovascular disease a leading cause of maternal mortality? Well, pregnancy is the quintessential cardiac stress test, right? So many physiological changes that occur during pregnancy, every system in the body has to adjust to accommodate the growing pregnancy. And then the cardiovascular system has many changes to heart rate, pulse, cardiac output, total blood volume. And so we know there's an overall decrease in systemic vascular resistance related to pregnancy hormones. And then the maternal heart rate increases approximately 10 to 15 beats per minute above the normal baseline. And it can go as high up to 40% baseline in multiples. And then the blood volume increases up to 50% by the third trimester. So about 1.5 liters increase in blood volume to maintain blood flow to the uterus and the maternal and fetal tissue. So here specifically, we look at the cardiac output changes. In the first trimester, you have 20% greater than pre-pregnancy values due to stroke volume. And I want to highlight this here because we're going to talk about some conditions today where the patients can get into trouble as early as the end of the first trimester, early second trimester. So we can't exclude this important factor right here. In third trimester, cardiac output goes to 30% greater than pre-pregnancy values due to increase in the heart rate and stroke volume. And then in labor, up to 50% increase in cardiac output during the first and second stage due to shunting. Here, we already talked about the different timings in pregnancy, but I wanted to highlight that early postpartum, you can have an increase of 60 to 80% immediately, and then it rapidly decreases within the first hour. But then even after that, you have an increase of at least about 500 mLs due to auto transfusion postpartum as well in the plasma volume. So really understanding the changes that happen. And yes, 3 to 6 months postpartum, they should have all these things should have returned to normal, but you can see how these pregnancy effects still linger on for a while and why women still have risks related to the pregnancy that extend out into the postpartum period. Next question. What is the most common presentation of heart failure during pregnancy or postpartum? Is it dyspnea, shortness of breath, palpitations, chest pain, or swellings of the legs and feet? And the answer actually is dyspnea and shortness of breath. I have this slide here just to identify. So I will have a number of icons represented throughout the presentation that you see that represent particular signs and symptoms that can lead or result in the perfect storm, which is heart failure. And heart failure is the focus of what we're talking about when we're talking about cardiac disease and maternal mortality. And as you can see here, some of these different signs will correlate with things like, you'll notify the heart, which signifies tachycardia or arrhythmias, and symptoms may be palpitations or syncope that your patient is complaining of. You see the water droplet, the vital signs may be, tachypnea, tachycardia, hypoxia, volume overload. The symptoms may be swelling, orthopnea, shortness of breath. Hypertension, you'll see an arrow. Headache may be a symptom, but it may just be the vital sign itself. Chest pain, signified by the lightning bolt, identifies ischemia, and patients may describe different types of chest pain that they feel. Hypoxia, signified by the lungs. You might have patients complaining of syncope, pleuritic chest pain, altered mental status. And then tachypnea, so they might have dyspnea, cough, shortness of breath. Ultimately, all of these things can lead to heart failure. And that's what I want you to pay attention to. So just take a look at the slides. Everything that we talk about and everything you see, all of these things play a role and can lead to heart failure. So next, we're going to review the most severe cardiac conditions with the highest mortality risk. So these are the patients who have known cardiac conditions and we know can lead to significant problems and potentially have higher risk of maternal mortality and maternal morbidity. So what patients are at highest risk of a cardiovascular event during pregnancy or postpartum? These are going to be your WHO class 3 and 4 patients. So these pregnancy risk class 3 patients have a significantly increased risk of maternal mortality or severe morbidity with a 20 to 27% maternal cardiac event rate. These patients, if they remain pregnant, should be followed by cardiology Q1 to 2 months. For your WHO class 4 patients, these are the patients in which pregnancy is actually contraindicated. So we don't recommend that these patients be pregnant. They have an extremely high risk of maternal mortality or severe morbidity. They have a greater than 27% maternal cardiac event rate. So these patients, you should discuss induced abortion. Right here, I'm going to pause for a second to say that we are here in Georgia, and we know that we have House Bill 481, which is the abortion ban of pregnancies or abortion of pregnancies beyond 6 weeks gestation or when there is a detectable heart rate, except for in certain circumstances. And so we know that there is a ban here. So many of us may, not think about it, but really and truly in patients with WHO class 4 conditions, it is our job still to tell these patients that pregnancy is contraindicated. So if you have a patient that has a condition who is now pregnant, you need to discuss pregnancy termination in this patient. Even if the patient lives in a state where there is an abortion ban in place, the patient may choose to electively terminate and receive those services in another state. And so they should be given this information and still allowed to understand what their rights are. And some of them may choose to terminate depending on how serious their condition is, but definitely the patients with class 4, WHO class 4 conditions, termination should be discussed and any resources offered. If the patient elects to continue with pregnancy, patients should be followed by cardiology at the minimum monthly. These patients are probably going to be seen a lot more often than that, but they should be seen at a minimum monthly if they have a WHO class 4 condition. So here's a list here of the severe maternal cardiac conditions, WHO class 3 and 4. Of those, the class 4 conditions are listed in red. So those are the ones which pregnancy is contraindicated. And I'm briefly just going to mention these. So mechanical valves, systemic right ventricle, Fontan circulation, moderate left ventricular impairment. That's an EF of less than or equal to 45%, but not as low as 30%. Severe left ventricular impairment, so EF of less than 30%, that is class 4 and pregnancy is contraindicated. Cyanotic heart disease, unrepaired, other complex congenital heart disease, aortopathies, like Marfan's, Ehlers-Danlos, Loeys-Dietz, pulmonary artery hypertension of all types, pregnancy contraindicated, severe systemic ventricular dysfunction, previous peripartum cardiomyopathy without residual impairment, but with any residual impairment is a class 4 and pregnancy is contraindicated. Moderate mitral or aortic stenosis is class 3, but severe symptomatic mitral or aortic stenosis is class 4 and pregnancy is contraindicated. And again, pregnancy contraindicated in Marfan's with a dilated aorta greater than 45 millimeters or aortic dilation greater than 50 with a bicuspid aortic valve or native severe coarctation. You can scan the QR code here if you'd like to access this pregnancy risk classification and see for yourself the different conditions that are listed. I'm going to highlight these severe maternal cardiac conditions, really focusing on these are the patients, if you know they have these conditions, have a significantly increased risk of maternal morbidity and maternal mortality. So these are the patients we know that have a significant risk of dying in pregnancy. And so we're going to talk about these conditions first. And so the first is cardiomyopathy or heart failure. So it's identified as the underlying cause of over 9% of in-hospital deaths among pregnancy-related hospitalizations, and cardiomyopathy represents the largest group of women who present with heart failure. Risk of cardiovascular events, adverse events is nearly 50% in patients with known cardiomyopathy. So we're talking about patients with known cardiomyopathy and heart failure. And so again, here, realize that many of the pregnancy symptoms mimic cardiovascular disease, so swelling, fatigue, orthopnea, palpitations. Many have a history of arrhythmia, valvular disease, or MI, can be genetic or associated with alcoholism, drug use, previous myocarditis or chemotherapy, usually likely to have elevated blood pressure or diagnosis of hypertension. And then again, adverse events associated when you have these EFs that are below 40%, or definitely when pregnancy is contraindicated less than 30. And so the risk factors there of what we think advanced maternal age, multiple gestation, smoking, African American. So again, these are patients with known cardiomyopathy or heart failure and common things that we think about. Really important with peripartum cardiomyopathy. This typically presents in the early postpartum period. So these patients will commonly get into problems then, and it can be associated with severe heart failure, cardiogenic shock, arrhythmias, and lead to even death. So again, really important to pay attention to peripartum cardiomyopathy and when it can present. So heart failure with preserved ejection fraction in pregnancy, just one type of heart failure in pregnancy. Again, not intending to help you become a cardiologist by any means, and not even pretending to know as much about heart failure to be able to give a full lesson in this. But this slide, I really wanted to highlight. This is in the American College of Cardiology. One of the articles just represented how many different ways patients can get into trouble with heart failure in pregnancy and what things happen that basically, again, end up in the perfect storm, which can lead to heart failure. Remembering some of these obstetric conditions like C-section, preeclampsia, multiple gestation, older age puts you at significant risk as well. And remember too that cardiomyopathy is just one cause of heart failure, right? You also have ischemic heart disease, pulmonary hypertension, valvular heart disease, congenital disease in the adult, and arrhythmias. And so this was an article in JAMA that was also cited by the American College of Cardiology, just showing you that cardiomyopathy is one cause of heart failure, but all these things can lead to heart failure. And so I put this slide in here to just remind everyone, any of these severe conditions can lead to heart failure, which ultimately can lead to death, right? So that's what we're focusing on today. So all of these things, aortopathies, congenital heart disease, cardiomyopathy, severe aortic stenosis, so all these WHO class 3 and 4 conditions can lead to heart failure. And so we're going to briefly talk about each one. And remember, some of these slides have been taken from the CMQCC, the California Maternal Cardio Care Collaborative, I'm sorry, and the California Department of Public Health. And so their slides are available on their website. They have a toolkit on cardiovascular disease in pregnancy, which is where this cardiovascular screening comes from. And so you'll see some slides that have been pulled from there. But again, their slides are available to anyone, so you can go to their website and use the resources and the toolkit that they have. So second, we're going to talk about myocardial infarction and coronary artery disease. So there are two basic types: spontaneous coronary artery disease, or SCAD, and pregnancy-associated myocardial infarction, PAMI. And so the most common etiology in pregnancy is SCAD. Typically, the symptoms are a ripping or tearing chest pain that patients present with. These patients, though, do not commonly have known pre-existing coronary artery disease, right? But it can lead to heart failure and death. And then risk factors, of course, the typical risk factors: chronic hypertension, diabetes, smoking, thrombophilia, advanced maternal age. Remembering that they all can lead to heart failure and death. And so again, this is just showing here SCAD or PAMI. Most commonly, SCAD is related to hormonal changes in estrogen and progesterone that can lead to changes in the vessel wall. PAMI, you have increased thromboembolic disease in patients with undiagnosed pre-existing coronary artery disease that can associated with hypertension. So that's why your blood pressure goals are to remain normotensive, monitor blood pressure and heart rate. But again, these are patients who have these conditions that are known. And then risk factors include these others, right? So multiparity, Marfan's, Ehlers-Danlos. So thinking about things where patients have changes in the vessel walls already, autoimmune disease, infertility, pre-existing hypertension, all the things. Next is pulmonary artery hypertension. So again, this illustrates exactly how there are multiple ways that patients with pulmonary artery hypertension can end up in right ventricular heart failure. And so you see all the different icons here, but all these can lead to that. And so this was pulled from an article from Columbus, Ohio, in their heart center there, just really emphasizing the high mortality rate, which is why pregnancy is contraindicated in this condition. And if they continue with pregnancy, they should be managed at a tertiary center that specializes in pulmonary arterial hypertension in pregnancy. And these patients need to be seen as early as possible, as often as possible. Aortopathies. So these are patients with Marfan's, vascular Ehlers-Danlos, bicuspid aortic valve, Turner's, Loeys-Dietz, familial thoracic. So they have an increased risk of aortic dissection during pregnancy and in the postpartum period. the aortic root diameters of greater than 4 centimeters actually may qualify for replacement prior to pregnancy. So if they have known before, we actually recommend that they have it replaced before pregnancy. But you may have patients that qualify for or should have surgery during pregnancy, depending on how dilated the aorta is. Remember, uncontrolled hypertension or tachycardia can lead to dissection or rupture. And these patients will have massive hemorrhage, stroke, cardiac tamponade, and death. And this has a high mortality rate. And what's really important about these patients is you get no warning signs. So these patients, you need to know they have these conditions. You need to have a baseline CT scan and echo so that you know if they have aortic dilation, and if so, that it's been measured so that you can counsel your patient appropriately. Because again, these patients, if they meet criteria, should be offered a termination or informed that pregnancy is contraindicated if their aorta is dilated above certain dimensions. And these patients should be given that, because these patients will not give you any warning signs. When these patients present, they may be normal, totally normal, all of a sudden have increase in blood pressure, increase in heart rate, and have a catastrophic event and ultimately die. Valvular disorders. So aortic stenosis. So really not going to go through all of the information on this slide, but again, this is one example of how the normal physiology of pregnancy can lead to events and severe events, and moms can get into trouble with aortic stenosis. These lesions, stenotic lesions, the patients are very volume sensitive, and these patients can get into problems early in the pregnancy. And so I want to highlight that, you know, you see the increase in cardiac output in pregnancy leads to worsening left-sided stenotic lesion. And as the cardiac output increases, ventricular pressure increases, which leads to symptomatic heart failure, arrhythmia, and syncope. So again, these patients, it's normal. They're going to have their systemic vascular resistance to decrease during pregnancy, which is normal, but then you also get the decreases in the diastolic blood pressure, leading to decreased coronary perfusion. And then when you don't perfuse your coronary arteries, you get ischemia and then heart failure again and death. And so really important in these patients to watch them for any signs or symptoms early on. If these patients also have valves that have been repaired, you also need to ask your patients how long it has been. Most of these valves have an expiration date. And if it has been beyond that, if it's been beyond 10 years, 15 years, depending on what type of valve they have, I can almost guarantee you these patients will have an event, and many of them will die if they have an event. So you have to be very cognizant of when their valve was repaired, and if they become symptomatic, if it's time for them to need a repair, because many of these patients cannot tolerate the fluid shifts and the increases in blood volume, and will get into problems as early as the late first trimester, early second trimester in pregnancy. So very important that you watch for this. And again, a diagram showing you the systemic vascular resistance decreases in pregnancy is normal, decrease in diastolic blood pressure, decreases in coronary perfusion to the myocardium, ischemia of the heart muscle. Then you get left ventricular heart failure, decreased cardiac output, decreased coronary perfusion, ultimately leading potentially to death in these patients. And so really important, again, some of these patients may warrant valvular replacement prior to pregnancy. And again, some of them may require a valve replacement even during pregnancy because of the high risk of an event during pregnancy. Potential complications, again, arrhythmias, aortic dissection, urgent surgery, heart failure, even death. Okay, that's why pregnancy is contraindicated in severe aortic stenosis. In mitral stenosis, it's a little bit better tolerated than aortic stenosis, but you still have about a 30% increased rate of a cardiac event. And it can be smaller with smaller valve areas. And if they're symptomatic prior to pregnancy, that's why it's also contraindicated in severe mitral stenosis as well. Again, this is, again, talking about how the patients can get into trouble. Here, what I want to, highlight here is these patients tend to get worse between 24 to 34 weeks, and again, in the postpartum period. So you really have to monitor BNP levels in these patients and avoid fluid overload and tachycardia. So again, thinking about the ways that these patients can get into trouble, there are a number of different ways. These lesions are so complex that this is why severe symptomatic mitral stenosis is contraindicated. Pregnancy is contraindicated as well. So for regurgitant lesions, these are typically very well tolerated in comparison to the stenotic lesions. So I'm not going to go into these. You mainly want to monitor for pulmonary edema and fluid shifts in the postpartum periods where they tend to get into trouble, but not as a high risk of maternal mortality as the stenotic lesions. And then lastly, congenital heart disease and arrhythmias are the other two severe maternal cardiac conditions. There are a number of different cardiac conditions in these two categories, which I'm not going to go into. But what's really important for them is if your patient presents pregnant with these conditions, you really want to know what these lesions are, what these conditions are. Have they been repaired? Are they under the care of a cardiologist? And really have them evaluated very early, because they are going to be at risk of different things at different times. And some of these patients may have had repairs, but may need subsequent repairs because pregnancy is an additional stressor. And again, some with the arrhythmias like heart blocks and things like that are going to get into trouble when you talk about things like anesthesia or needing an increased heart rate during labor. The patients can really get into trouble if they can't mount responses. So these conditions can be vast in these areas, and you need to have the patients really in close communication and consultation with their cardiologist to ensure that you are caring for these patients very early on to anticipate any potential complications. So again, we reviewed these severe maternal cardiac conditions because these are your patients at highest risk of having a cardiac event, and these are the patients at highest risk of death during pregnancy and postpartum. And so remember, all these conditions can lead to heart failure, right? So all of them can lead to heart failure. One of the things that we did here at GAP QC was we put together this Cardio OB Acute Care Guide. This pamphlet basically has all the conditions we just discussed and has a little bit more detail about what kinds of things you should or should not do if these patients present to you acutely during pregnancy or early postpartum, so that you don't worsen their condition when they present. It's basically almost like a get out of jail free card. So if these patients present, it's what to do at 2 o'clock in the morning. You don't have all the help that you need, and the patient presents symptomatic. This will help you identify things that maybe you should or you shouldn't do. So should I give them IV fluid? Should I not give them certain medications? So should they get an epidural if they need to be delivered? So all of these things are included in the Cardio OB Acute Care Guide. This was developed with in conjunction with cardiologists, maternal fetal medicine, obstetrician, and anesthesiologists. So they all contributed to this and ensure that the information here is correct. You can access this by the QR code, and you can have these printed on the website. Again, this is also the same thing available in a digital copy that you can use, or in a poster form that you're going to have posted anywhere where you evaluate or chart for patients that are seen in acute settings. And we also put the information in an app. So one of my residents, actually, former residents, made this into an app. All the same information is available. Unfortunately, it's only available for iPhone users or iPad users, but you can scan the QR code to be able to use this. And again, this is to be used for the care of patients in acute settings that present with known cardiovascular conditions that are the class 3 or class 4 WHO conditions. So next we are going to talk about understanding the importance of implementing cardiovascular disease risk assessment and the steps included in screening for cardiovascular disease risk. So why do we even need to think about screening and talking about cardiovascular screening? Because we're missing the mark when we talk about improving maternal mortality related to cardiovascular disease. So many of our patients, we found that there was a delay or inadequate response to clinical signs and symptoms, ineffective or inappropriate treatment. So patients being treated for pneumonia instead of being treated for heart failure, misdiagnosis. So same thing, patients, being misdiagnosed is one thing instead of the other, and then a failure to refer or consult. So that's why we're talking about this, because we need to do better at diagnosing and identifying patients with cardiovascular disease. Some of the benefits of screening are that you increase patient and provider awareness, right? So now the providers know to include cardiovascular disease in their differential. We know for a long time that many of the symptoms would be dismissed in pregnant women, but now that we know they have an increased risk of morbidity and mortality, more providers are having this on their differential appropriately so. And then patients are now more aware and more likely to seek care. It helps you identify patients at increased risk, so we can now get them in with appropriate follow-up with cardiology, and it gives us an opportunity for further testing and a heightened observation. And then we're able to modify some risk factors, hopefully, and improve maternal and fetal outcomes, and gives us an opportunity to decrease long-term effects of cardiovascular disease too. Some other important points are that for some women, the first presentation of cardiovascular disease may be during pregnancy or early postpartum, which is why we're talking about screening. And then between 24 and 28 weeks or postpartum is the time when women are at greatest risk for worsening cardiovascular disease symptoms. So starting to get into that third trimester and then postpartum is where women are most at risk. Cardiovascular disease symptoms and vital signs abnormalities should not be ignored in the pregnant or postpartum patient. And we're going to re-emphasize that over and over again. And then remembering to screen women who are pregnant and up to 365 days postpartum can help identify these women, going back to one of the first slides we showed on the timing when these patients are having events, and most of the deaths were occurring in the postpartum period, 71%. An important finding that we know about as well now is that preeclampsia and cardiovascular disease are early indicators of future cardiovascular disease in women. So if you have preeclampsia, you double the risk of developing a heart attack or stroke. If you have preeclampsia diagnosed before 34 weeks, you have 4 times the increased risk of developing cardiovascular disease. Specifically, patients who have preeclampsia with severe features or have preeclampsia with more than one pregnancy have an increased risk of developing cardiovascular disease when compared to patients with either mild preeclampsia or preeclampsia in only one pregnancy. And then in 2011, the American Heart Association even added preeclampsia, gestational diabetes, and elevated blood pressure in pregnancy as risk factors for developing heart disease. So this is something that we now know is well known and well documented, and even the AHA has now added it as a risk factor for developing heart disease. So while the WHO class 3 and 4 patients that we just talked about are at highest risk of a cardiovascular event during pregnancy and postpartum, the majority of patients that present with a cardiovascular event have no history of cardiovascular disease. I can't emphasize this enough, and this is why we are here today. Most of your patients are not going to be the patients that we just talked about with aortic stenosis or aortopathies or peripartum cardiomyopathy. So most of your patients are not going to be those patients. Most of your patients are going to have no history of cardiovascular disease whatsoever, and they're going to present for the first time with a cardiovascular event. So cardiovascular disease screening in pregnancy and postpartum is focused on identifying patients with heart failure and myocardial infarction, right? Remember what I said before, all those roads and the severe conditions lead to heart failure. And we know MI is one of those as well. So we're focused on identifying patients with those, and that's what the screening tool has been focused on. So next question, which biomarker has been shown to aid in the diagnosis of heart failure? Is it B-type natriuretic peptide, BNP? Is it C-reactive protein, creatinine kinase, troponin, or lipoprotein-associated phospholipase A2? I think most of us know here that the answer is going to be BNP, right? So we know BNP in pregnancy. Pregnancy is a state of physiologic volume overload, right? We talked about in the beginning how your pregnancy blood volume increases by about 1.5 liters. We also know that the left ventricular wall mass and diastolic dimensions also increase in pregnancy. And some clinical uses of BNP in pregnancy, used in the diagnosis of heart failure in women with dilated cardiomyopathy. Higher BNP predicted adverse cardiovascular outcomes. It's also used in asymptomatic left ventricular function, so useful in evaluation of shortness of breath. And remember, we talked about shortness of breath being the #1 presentation of women with symptoms in cardiovascular disease in pregnancy. And then a predictor of cardiovascular outcomes. So in pregnant women with congenital heart disease, higher BNP levels was associated with poorer outcomes. And so these are the clinical uses of BNP and why it's included in this screening tool here. These are normal BNP levels that they identified in the CMQCC by some studies, and found that the highest, I always look at the highest here, got to about 26.5, 27. So if you know that, then that'll help you remember, what values can be used. And so the next question leads us into what BNP level is diagnostic of heart failure? Is it going to be A, 10, 50, 100, 450, or 900? The answer here is going to be 100. So BNP levels of 100 or above are consistently diagnostic of heart failure. And so if you look here, a BNP of greater than 50 but less than 100 is suggestive of heart failure, and an NT-proBNP, which may be used at your institution, of greater than 450 but less than 900 is suggestive. But then diagnostic of heart failure is a BNP of 100 or greater, NT-proBNP of 900 or greater. So again, if you think about it, Diagnostic BNP is 100. Half that is going to be suggestive of heart failure. Same for NT-proBNP. 900 is diagnostic. About half that, 450, is going to be suggestive. So if you have that, then you may need to proceed to the next step of getting an echo plus or minus cardiology consult, depending on what you find. So again, pre-existing cardiovascular disease and or new onset peripartum cardiomyopathy may initially present during pregnancy or in the postpartum period. And remember, some of these physiologic changes gradually return to baseline by 2 postpartums, so your patient should not be getting worse, right? If you have a patient that's coming in with worsening symptoms in the first week after delivery, you need to have a heightened sense that this could be cardiac. Peripartum cardiomyopathy most frequently presents in the first postpartum week, with 75% of the patients presenting in the first month. And then pregnant or postpartum women with cardiovascular disease frequently present with shortness of breath or a new onset cough, which we talked about again. This is the #1 classic presentation of women with cardiovascular disease in this period. So when a woman presents in the postpartum period with complaints of shortness of breath, you should make sure that you ask, does she have worsened level of exercise tolerance? Does she have difficulty performing activities of daily living? Symptoms that are getting worse and not better. Chest pain, palpitations, dizziness, new onset cough or wheezing, lower extremity edema. Is it getting better or is it getting worse? Unexpected fatigue. Does she have to stop to do, while she's walking and do routine activities? Can she lie flat or does she have to be propped up on pillows? How many pillows does she have to stay propped up on? Is she gaining weight after pregnancy? Because these women should be losing weight and losing it fairly quickly. And then does she have a history of cardiac or pulmonary conditions, a history of substance abuse and or tobacco use? And has she been seen by other providers or in emergency departments since giving birth? I can't highlight this enough. Of the maternal deaths that I am aware of, both in Georgia and outside of the state, the majority of the women presented to multiple ERs prior to their final presentation. And so these women are screaming for us to identify the problem. Remember, if these women are showing up in your emergency room, they are newly postpartum. So they either have the baby at home or kids at home or in the NICU. They have plenty of things to do that they do not want to have to come into the emergency room. These women are coming into the emergency room because something is wrong. And if there is something that we can do to identify it, that's what we're here to talk about today. So now we're going to get into the nuts and bolts of what we're talking about today, which is the cardiovascular disease screening. And again, some of these slides pull from the CMQCC's toolkit. So, any of these that you see with their logo here were taken from the toolkit there, which are available to everyone. So this algorithm was validated, and they applied the algorithm to 64 of the deaths that happened in California between 2002 and 2006, and identified that 88% of the cases of maternal mortality would have been identified ahead of time had this screening tool been applied. And then that detection rate increased to 90% when they restricted it to the cases that were symptomatic. So that alone is the #1 reason that this screening tool has been endorsed by ACOG and other entities across the US. And so this is why we're really highlighting potentially we can save lives by screening these women for cardiovascular disease. So now we're going to talk about the who, the when, the how do we screen, right? So this chart differentiates which patients require prompt evaluation in the hospital setting by identifying history, symptoms, vital signs, and physical exam findings that are most concerning, right? This chart was taken from the ACOG Practice Bulletin on Pregnancy and Heart Disease. And so it identifies, the caution column. This is where you should slow down and say, do I need to do something? Or the stop. Pull out all the stops. This patient do not pass go, do not collect $200. You go straight to be evaluated at the hospital, depending on what signs and symptoms you have. And so here again, the same ACOG Practice Bulletin talks about what patients should be risk assessed, what's recommended, and when they should be referred for higher levels of care. It says who should be screened, all women. When should they be screened, antepartum and in the postpartum period, and how should they be screened using the California CMQCC two-step protocol, which is identified here in the diagram on the left. And so this is the screening algorithm here, and there are actually 2 versions of the same thing. So on the left is the CMQCC two-step, so California's what I call the two-step screening algorithm, and on the right is a modified version, which has been endorsed by ACOG, but also endorsed by the American College of Emergency Physicians as well. And so they combine these 2 steps into one. I'm going to talk a little bit about both just so you're familiar with both and know that you can use either one in your setting to be able to apply it to your patients and hopefully identify your patients with cardiac events or increased risk of cardiac events during pregnancy. The CMQCC is separated into 2 steps. And so the first step is what we have labeled the maternal cardiac warning. And so these are the patients that you need to stop. You need to stop and send these patients over for immediate evaluation. And so these are patients with red flag symptoms. So shortness of breath at rest, severe 4-pillow orthopnea, resting heart rate of greater than 120 or greater, resting systolic blood pressure 160 or greater, respiratory rate of 30 or greater, or O2 saturations of 94% or less. These patients require prompt evaluations. So these patients with red flags, with or without a history of any cardiovascular disease history. And then over to the side, they talk about patients that just have a personal history of cardiovascular disease without red flags. Those patients still warrant consultations with MFM, maternal fetal medicine, and primary care cardiology. It doesn't really speak to when, but depending on what conditions they have, and we talked about some of those severe conditions, then you may decide how soon those patients need to get in to be evaluated if they don't have any red flags. Step 2, so say you have a patient with symptoms and she doesn't have any history of cardiovascular disease, but she has some symptoms and some vital signs and risk factors that you are considering whether or not she needs a full cardiac workup. And so there are 3 categories, basic categories: symptoms, vital signs, and risk factors. And then over to the side, there's also physical exam. And how you go about assessing the patients here is if they have 1 symptom, 1 vital sign, 1 risk factor, so they have at least 1 in each category, or if they have a total of 4 in any combination, right? So if they have a total of 4 of these factors, combination from symptoms, vital signs, and risk factors categories, then you would go on to the next step and complete your evaluation, begin your evaluation. Separately, if you have physical exam findings, so abnormal findings of a loud heart murmur or bibasilar or basilar crackles, then these patients should get immediately seen and consulted by MFM and primary care cardiology, and also start the workup as well. This is the ACP endorsed version. Again, you can scan the QR code there for access to it directly. And again, this is a more recent version that has been endorsed by ACOG, which also simplified it so they're not 2 separate steps, but they simplified the red flags and kind of put all of those together. And I'll talk about the differences in the 2, but they're very similar and you can use them interchangeably. But this is the one that they are endorsing for more emergency medicine physicians or acute settings, and I'll talk about why shortly. This one starts by asking, are you pregnant or have you been pregnant in the last 12 months? Because they wanted to highlight with emergency physicians and emergency providers that these patients very well may be postpartum, right? And so many of these patients may not tell you that they just had a baby or they were pregnant. Some of the patients may have had a miscarriage, they may have had an abortion, right? So if you just ask them, have you had a baby in the past year, they're going to tell you no, right? Or they may not want to say, that they had an abortion, but if you ask them this question, the patients are most likely to answer yes, whether they had a miscarriage or abortion or otherwise. But again, getting you to realize that you need to be, as an emergency provider, as someone seeing patients in these settings, you need to have a heightened sense that these patients are at risk, and therefore you should be asking the question about recent pregnancy. And then next, what they did was combine the section on red flags and include some of those 2-step symptoms and risk factors here and put them all together. So shortness of breath at rest, chest pain at rest with minimal exertion or ripping or tearing in quality, palpitations associated with near syncope, severe orthopnea, heart rate of 120 or greater, systolic blood pressure of 160 or greater or less than 90, respiratory rate of 25 or greater, O2 saturation of 94% or less, and then allow systolic murmur, diastolic murmur, S3, S4, wheezing, crackles on lung exam, or distended neck vein. So again, you can see here how they just combine a few of the section into the red flags, but either of these 2 screening algorithms can be used, and they have both been endorsed by ACOG and basically will still lead you to the same result. So if your patient screens positive or at risk, now what? What do you do next? So the next steps are highlighted here. So the next step again, starts off with an EKG and BNP, right? So we know we're looking for heart failure in these patients. We're trying to identify the patients at highest risk, and these patients are going to end up in heart failure. That's what we're looking for. So start by ordering an EKG and BNP. Depending on your results, then you can decide whether or not you need a chest X-ray and echo. And then other things we'll talk about a little bit later, but really starting off with those basic things. EKG and BNP and then does the patient need an echo and chest X-ray? And so in the ACEP endorsed version, the only difference is that they don't separate the steps of ordering the chest X-ray. So they added a chest X-ray, and they also added a troponin, really identifying that patients presenting in acute settings and more acute settings instead of maybe the office are going to have more complaints of chest pain. And so wanting to identify the patients at risk for MI or of MI or SCAD. So really identifying those patients that are also going to present with those conditions. So heart failure and PAMI or SCAD, you really want to make sure that they included adding a chest X-ray and troponin in that first step. So there's EKG, BNP, but also chest X-ray and troponin in the first step in the initial cardiac workup. So basically the same. So again, if the patient screens at risk or positive, start with EKG, BNP, and plus or minus troponin if they have complaints of chest pain, but then also consider other tests depending on the patient's symptoms or complaints. CBC, BNP may be thyroid function if the patient has fever, tachycardia, hypertension, because maybe this patient is presenting in thyroid storm. D-dimer, we know that's elevated in pregnancy, but it can be considered because of its high negative predictive value, right? So it'll help you rule out things when you think there might be a clot or a DVT, right? ABG, if the O2 sat is low, of course. Tox screen, remember substance abuse is a strong risk factor for pregnancy-related cardiovascular disease. So you may need to get it just to help you along with the diagnosis, but realize that even so, these patients can still present in heart failure. And then imaging-wise, a chest X-ray, frequently normal in asthma, but it's recommended in the first step in patients that present. And then echo, you should be ordering depending on the results of your BNP or NT-proBNP, right? Venous Dopplers you consider, and or CT angio if you're thinking about a PE, or Dopplers if you're thinking about a DVT, 24 Holter monitor if you're thinking arrhythmia, and again, cardiology consultation as needed. So this is what you do for patients once they're screened, but remembering the things in red, that's what you start off with first. And then leading to next steps, again, for anybody that screens positive with BNP and NT-proBNP suggestive of heart failure, echo is going to be your next step along with your cardiology consultation. So now we're going to get back into some case presentations. And starting off similar to that first patient that we started off the presentation with, 25-year-old obese African-American G2P2 presents 10 days after an uncomplicated vaginal delivery with fatigue, persistent cough, shortness of breath, dyspnea since delivery. Little hypertensive, 150/98, heart rate's 119, respiratory rate 22, afebrile, O2 sat 94% on room air. She gets screened using the cardiac screening tool, and EKG, NT-proBNP, troponin, and chest X-ray are ordered. So, going back here, this patient has red flags, right? So she's an O2 saturation of 94% or less. So that screen at risk or positive because she has a yes to at least any one of the red flags. So this patient gets promptly evaluated. And if you were going to use the ACEP endorsed version, again, if you look at this the same way, patient has an O2 sat of 94% or less, therefore she warrants getting an EKG, BNP, troponin, and chest X-ray. So this patient has a positive red flag, she goes to the next step. EKG is significant for ST elevation. NT-proBNP is 750. Troponin is markedly elevated. More cardiac enzymes, coronary angiogram, and echo are ordered. Coronary angiogram is consistent with spontaneous coronary artery dissection, and cardiology is consulted. She's admitted to the CCU and treated for SCAD and remains in the hospital for 2 weeks until discharge home. She's followed by cardiology with Q1 to 2 month visits and brings the baby with her to her annual visit in your office when the baby is 1 year old. And so I put this here. This is a picture actually of my younger sister, Tiara, and she's a PhD who lives in Houston, and this is my nurse. And I put this here to make this personal. This wasn't her story exactly, but my sister in the first week postpartum called me about 11 o'clock at night telling me that, my legs are swollen. Do you think I need to go into the hospital? Because I know, what can happen. And so I went through a series of questions and asked her a bunch of different questions. And I told her, you have no other symptoms. You're probably okay. Let me know if you start to have these symptoms or shortness of breath or other things. But I can't deny that I had a moment of hesitation because I thought to myself, what if something else is going on? Should I have told her to go in? So luckily she didn't have a cardiac event. And now she's made it past my niece's first birthday. But again, I put these pictures in here of people that I know to really bring it home and make it personal so that you understand these symptoms can happen to anyone. Remember, red flag signs or symptoms require immediate evaluation. So these patients should not go home without a cardiac evaluation. And if patients are symptomatic but without red flags, that's when you consider further workup or evaluation if other signs and symptoms are present. So same case, just a little bit different. 25-year-old obese African-American, G2P2, 10 days postpartum after vaginal delivery, fatigue, persistent cough since delivery. This patient's normal intensive, heart rate's 110, respiratory rate 24, afebrile, O2 sat of 95% on room air. She gets diagnosed with presumed new onset asthma and is prescribed a beta agonist. 1 week later, she presents again with continued symptoms and complains that the inhaler is not working. The resident applies the CVD screening algorithm and has the following findings: respiratory rate 28, oxygen saturation 95% on room air, heart rate 110, African American, asthma is unresponsive to therapy. Patient screens positive for CVD risk. And this is just showing you here, this patient had at least one in each of the 3 categories, right? So they had at least one symptom, one vital sign, one risk factor, but also was screen positive because they actually had, all that added up to more than 4. So either way, this patient was screen positive by both ways, right? So at least one symptom, one vital sign, one risk factor, or adding up to at least 4 total. And then that patient warrants going to the next step. So again, positive risk assessment, at least one in each category, or any combination of 4. So again, on the ACEP endorsed version, this patient had a respiratory rate of 25 or greater. So that's a red flag. That patient automatically screens positive, goes to the next step. A chest x-ray, EKG, and BNP are ordered. Chest x-ray revealed mild pulmonary edema. EKG is significant for sinus tachycardia. BNP 220 echo is ordered. Echo shows an EF of 40 to 45%. Cardiology is consulted and she is admitted to the CCU and treated for peripartum cardiomyopathy. Remains in the hospital for 8 days until discharge home. She's followed by cardiology with Q3 month echo and brings the baby back with her to her annual visit in your office when the baby is 1 year old. And so this here is Dr. Amberly Winley. She's actually an OBGYN herself. She's also my patient. I delivered her twins here. And after her delivery, she had symptoms. She had symptoms of chest tightness and chest pressure. And we did a workup, which included a BNP and echo. Gratefully, her BNP was a little elevated, but her echo was completely normal. She did have some pulmonary edema and some fluid overload. So we had to treat her with Lasix, but you can imagine that she was concerned as I was concerned. But again, if something as simple as getting a BNP steering you in the right direction is going to help you identify a patient potentially with heart failure, I think it's well worth that. And remember here, new onset asthma in adults is rare. So really, again, shortness of breath in a pregnant or postpartum patient, we should not just be, chalking up to nothing or saying it's new onset asthma. We should be asking ourselves, why is this not cardiac, right? And again, don't be fooled. You can get patients to get better, right? So you can give her some asthma or some albuterol or a breathing treatment, and she may get better. That doesn't mean that she has asthma, right? CHF sometimes also improves on bronchodilators. So don't fool yourself into thinking this is not cardiac. If the patient warrants a cardiac evaluation, use a screening tool and screen her appropriately. Same case, a little bit different. 25-year-old obese African-American female, G2P2, 10 days postpartum after an uncomplicated vaginal delivery with fatigue, persistent cough since delivery. Normal intensive, heart rate 119, respiratory rate 24, afebrile, 95% sat on room air. She gets diagnosed with a respiratory infection and is prescribed an antibiotic. Fatigue is attributed to lack of sleep. 1 week later, she presents to the family medicine office again with continued symptoms. The resident does a lung exam and identifies bibasilar crackles on inhalation and remembers the CVD screening algorithm. Patient is sent to the ED where an EKG, echo, and BMP and cardiology consult are ordered. The patient's labs and studies are consistent with cardiomyopathy. Patient is admitted and managed by cardiology. The patient is discharged home after a 2-week hospital course. So I put here a picture of my resident, Dr. Ashley Marie Jones. She was one of my chief residents. She's now an attending at our hospital. She did not have a cardiac event, but again, reminding myself that this can be any one of your patients, but specifically, identifying your Black patients as well. But again, anytime you have these patients, you're seeing these patients, think this could be my sister, this could be my aunt, this could be my best friend, this could be my sister-in-law. Always think, could this be someone that I know, right? And if it warrants something as simple as a little workup, an EKG, BMP, chest X-ray, troponin, is it worth it to identify these patients? Yes. And so in this case, this patient had the physical exam findings, right? So remember, loud murmur or basilar crackles, that means you go straight to cardiology consultation and MFM and further evaluation. And so again, remember, basilar crackles usually associated with heart and lung findings, so heart failure, pneumonia, pulmonary edema, and then a loud murmur is going to be a grade 5, which is audible with a stethoscope, lightly touching the chest, just reminding us, and this would screen at risk or positive by that alone. And this patient had crackles on lung exam, and so warrants a further workup because that's a red flag. So remember, symptoms related to physiologic changes of pregnancy should be getting better in the postpartum period, not worse. And then visits to the emergency department for dyspnea should raise suspicion for cardiovascular disease. And bilateral crackles on lung exam are most likely associated with CHF. And again, postpartum dyspnea or new onset cough is always concerning for cardiovascular disease. Again, pneumonia in immunocompetent adults is rare. So if the patient's presentation is inconsistent with infection, consider a cardiac workup. And, now we're going to talk about how do we screen these patients? How do we implement screening? First, you want to use a standardized validated assessment tool like the ones that we've identified here, either the CMQCC 2-step or the ACP ACOG endorsed version, and screen women in pregnancy and up to a year postpartum. And then you want to recognize the at-risk patients and have a standardized process for follow-up. So if you screen these patients, are you sending them to triage to get the initial evaluation? Are you doing it in your office? If so, how are you following up the labs and notifying patients that need to then go into the hospital and be evaluated? And then consult cardiology for those at-risk or positive patients so that they can get the treatment that they need to prevent further complications. So here, again, the same things, the maternal cardiac warning and watch that we created signs for and posters. You can post this anywhere that pregnant patients are evaluated. We also created a Gap QC badge buddies. These are available on the website. You can order them and have them shipped to your office. But we have these, and our residents and our faculty each have them on their badges. Excuse me. This way they can just pull it, take a look at it, screen their patients pretty quickly, and decide whether or not they need a further workup, whether or not they need to order EKG, BMP, troponin, and chest X-ray. You can also post these anywhere where you evaluate patients in the ED, in your urgent care. You can also add this to your phone so that you can just pull it up very quickly and be able to access it. And also some of your hospitals may have the cardiovascular risk assessment in their EHR. I know that Northeast Georgia has already incorporated this. We are working on it in our hospital system, although it's not live yet, but it's coming soon to an ED or a institution near you. And then where do you screen these patients? The answer is anywhere. OB triage, urgent care, emergency departments, outpatient offices, wherever you touch these patients up to a year postpartum, you should be screening them. So that's the end of the basic presentation. Lastly, I have here for just a few minutes, a few practice cases similar to the ones before, but much shorter. But we have a few practice cases. So if you want to stick around here, we can do a few practice cases just to get you more familiar with kind of screening and a few tips and tricks that I didn't go over before about some of the other types of patients. So here's a 43-year-old African-American G1P1, 6 weeks postpartum with congestion, shortness of breath, sore throat, subjective fevers, and chills. Blood pressure is 149/88, heart rate's 120, temp is 101.3. What is the best next step? obtain an upper respiratory panel, preeclampsia panel, EKG and BNP, albuterol breathing treatment. So which of these would you do first? So here, I would recommend doing an upper respiratory panel. So the patient here is febrile, and she does have a red flag symptom. So I'm going to address that too. So she is febrile though, so she very likely has an infectious cause, right? So we don't want to overlook that. So you should always start with ordering the respiratory panel, but realize she still has red flag symptoms. So if this patient, so you want to know first, does she have the flu? Does she have COVID? Does she have anything that is infectious that I need to treat? That doesn't mean that you won't still potentially order the EKG and BNP. So for a lot of people, and again, for me, you might just consider ordering the respiratory panel, but also ordering the EKG and BNP simultaneously, because she does have a red flag symptom. She has a heart rate of 120 or greater. So realize that this patient, you should get the respiratory panel just so that you know what you're dealing with and know if it's infectious or not. But realize that you also very likely are going to still order that EKG and BNP because the patient does have a red flag symptom. But just start with the respiratory panel just so you know what direction you're going. 34-year-old G3P2, postpartum day number 6, status post-vaginal delivery with chest pain and shortness of breath. Vital signs 156/93, heart rate 125, temperature is 99, O2 sats 96%. What is the best next step? Is it a preeclampsia panel, dose of IV Lasix, BNP, troponin, EKG, and chest X-ray, or CTA D-dimer? And so, you guys aren't OB, but some of you may be thinking, so while this patient is, postpartum and she's in the first postpartum week and she may have preeclampsia, the patient is still presenting with chest pain and shortness of breath. And so those two symptoms together kind of tip your hand in the direction of thinking of cardiac first, right? So she does have red flag symptoms. She's got a heart rate of 125, and she's also got this chest pain, right? So what is going on here? So she could have, some pulmonary edema and preeclampsia, but she could have heart failure. So you don't want to miss a cardiac event, which is why you should start here with the BNP, troponin, EKG, and chest X-ray, right? You want to be sure she's not presenting with a cardiac event. Doesn't mean that after that you're still not. So if that's negative, then I'm going to that next, right? I'm going to order my preeclampsia panel and see what's next, right? I may end up picking up some pulmonary edema and the fact that this patient is preeclamptic, but I need to be sure this patient is not having a cardiac event already. All right, 32-year-old G1P0 at 38 weeks. So this patient's still pregnant with a past medical history of asthma, presents to the OB/ED with cold-like symptoms for the past 3 days. She also reports worsening shortness of breath and wheezing, not relieved by her albuterol inhaler. She's afebrile and vital signs are stable. What is the best next step? So is it EKG, BNP, and chest X-ray, pulmonology referral, CTA D-dimer, or is it an albuterol breathing treatment? And so the key here is the patient's vital signs are stable, and she does have cold symptoms, which can exacerbate her asthma. So here, because her vital signs are stable, I would recommend starting with an albuterol, levobuterol breathing treatment, right? So start off with a breathing treatment in this patient because, again, her vital signs are stable. She has cold symptoms, and she hasn't been given really definitive therapy, which would be an albuterol breathing treatment. She's just been using a rescue inhaler. So, but if this patient, if she doesn't get better, could she at some point warrant a cardiac workup? It may be in order. If she starts having abnormal vital signs or otherwise, or shortness of breath doesn't get any better, then you may consider a cardiac workup. But initially, I would start with that because she is stable vital signs and has recent cold-like symptoms, which we know can exacerbate asthma. So I would start with a breathing treatment here. 32-year-old G1P1, past medical history of asthma, presents 3 weeks after a vaginal delivery with worsening shortness of breath, wheezing that is not relieved by her albuterol inhaler. Patient was seen in urgent care last week with similar complaints and states that the breathing treatment you prescribed are still not working. She's normotensive, heart rate 119, respiratory rate 24, temps 98.8, O2 sat 96% on room air. What is the best next step? So this patient now has asthma, which is refractory to treatment, right? She was seen last week, you gave her a breathing treatment, and she says it's still not working. And remember what I said about patients presenting multiple times to emergency rooms. Now she has, asthma that's refractory to treatment, and she still has some mild vital signs, right? So she's got a heart rate of 119, she's got a respiratory rate of 24, she's also got an O2 sat of 96%. So if you use a screening tool, she now warrants the EKG, BNP, and chest x-ray. So you need to start there to ensure that this patient is not presenting with a cardiac event. All right, 25-year-old G2P1 at 12 weeks with a history of a congenital heart defect presents to family medicine office for an ingrown toenail. Vital signs are 130/80 and a resting heart rate of 120. Patient is otherwise asymptomatic. What is the best next step? A, cardiology and/or MFM consultation. B, order baseline echo. C, IV fluids and pain medication. Or D, order EKG and BNP. So this patient has a known history of a congenital heart defect. So without knowing what it is, repaired or unrepaired, she has a red flag symptom, right? So she has a red flag symptom, regardless of if she was otherwise asymptomatic. You should realize that this patient has potentially a severe cardiac condition. You don't really know what it is, but it could be a WHO class 3 or 4 condition. And these patients can worsen after they become tachycardic and or hypertensive. So without knowing what her previous her congenital heart defect was, you should probably order EKG and BNP. She's got a heart rate of 120. You don't know where she stands. You don't know what this condition is. So it's best for you to at least say, okay, let me at least rule out heart failure in this patient and then proceed otherwise. All right, 35-year-old G4P2012 with a history of Marfan's disease presents to family medicine office at 6 weeks gestation for initial prenatal visit. Vital signs are stable and she's currently asymptomatic. After completing her first visit and prenatal labs, what is the best next step? A, outpatient referral to cardiology with visit in 1 to 2 months. B, consult OB MFM immediately for possible hospital observation and baseline echo. C, EKG, BNP, troponin, and chest x-ray. Or D, refer patient to Planned Parenthood or Feminist for termination of pregnancy. So remember here, although the patient has no symptoms of a cardiovascular event, the patient has a condition which, depending on the degree of aortic dilation, she could be at significant risk of death, and pregnancy might be contraindicated. So despite being asymptomatic, the right thing to do would be to consult OB and MFM immediately for possible hospital observation and baseline echo. Because again, this patient is not going to give you a warning sign. So, and I know she's had two babies in the past, but that could be years ago, right? So she could have had 2 babies 10 years ago. Now she's got a dilated aorta, and maybe she hasn't seen her cardiologist in a while because she's been doing okay, right? But now she's newly pregnant and she's 35. If you don't know what is the status of her aorta at this time, you really need that baseline echo. So you need to consult you need to consult and get an echo right away to see if she's got an aortic dilation, and if so, how large is it? Because the patient may be a class 4, WHO class 4, and pregnancy could be contraindicated. And while I know she's at 6 weeks, and in Georgia we have a 6-week abortion ban, she may decide, hey, my aorta is 5.2 centimeters. I don't want to take a chance. I don't want to continue with the pregnancy. That is her right. It is our job to educate her on her risks and on her options, and she may decide to go out of state to have a termination. It's totally up to her, but she should be given this information. The key here is, I know she's seeing you for this first prenatal visit, but you have to be able to say, wait a minute, you have a condition that actually could be complicated by something that pregnancy would be contraindicated. So let me figure out whether or not you have something now. And to wait and to let this patient wait 1 to 2 months is totally what should not be done in this case. She's asymptomatic, which is why you don't need the EKG, BNP, troponin, and chest x-ray. And remember, these patients with aortopathies, these patients are more at risk for a sudden catastrophic event. They don't usually present in heart failure. They usually present with some degree of aortic dissection or a rupture, right? So these patients are going to come in and give you no warning signs. So you need to know where the patient stands ahead of time so you can educate the patient on her risk and kind of what options she has. 30-year-old African-American female at 18 weeks gestation with a past medical history of peripartum cardiomyopathy with a previous pregnancy who presents to the family medicine office for an ankle sprain. While taking her history, you notice that she stops to breathe in the middle of sentences. She's normotensive and her urine is negative for protein, glucose, and ketones. What is the best next step? Is it an outpatient referral to perinatal cardiology, EKG, BNP, troponin, and chest x-ray, order an echo, give prescription for Lasix, and reassure the patient to follow up at the next routine prenatal visit? So this patient is at increased risk of a cardiac event due to her history of a cardiomyopathy. And you don't know, she's either a class 3 or a class 4, right? Either she's got reduced ejection fraction still, or she's got a preserved ejection fraction. So we don't know which one she has, but either way, she's class 3 or class 4. And if she is stopping to catch her breath in between sentences, then this patient is clearly symptomatic and needs a cardiac evaluation. And so you need to send this patient immediately to be evaluated either to the ED or to OB triage to have a workup initially. And she may warrant getting an echo, but you should start with the EKG, BNP, troponin, and chest x-ray to start. 35-year-old African-American G4, P4, she's 12 weeks gestation, so that should be G5, P4, 12 weeks gestation, presents for cough, shortness of breath. This patient has a history of aortic stenosis, status post biologic heart valve replacement 15 years ago. She's normotensive. Her resting heart rate is 115. Temperature is 101.3. O2 sats 95% on room air. Respiratory panel is positive for influenza. What is the best next step? Is it A, start IV fluids and begin Tamiflu? B, give her prescription for Tamiflu and have her schedule close follow-up visit in 7 days with MFM and cardiology? C, EKG, BNP, troponin, chest x-ray, and echo? Or D, supportive care and outpatient referral to cardiothoracic surgery to discuss valve replacement? And so here, what you need to be cognizant of is this patient does have a repaired aortic valve, but it's probably expired. 15 years is well beyond how long these valves typically last, which is for the most part, from what I gather, about 10 years on average. Some of them may be a little bit longer, but again, without knowing, this patient's valve is likely expired, and she's also symptomatic. So she doesn't have red flag symptoms, but she does have shortness of breath, and she has a cough with some kind of mild symptoms, right? So she's mild vital signs. She's got a heart rate of 115. She is febrile, and she does have the flu, but she's also got a sat of 95%. So while you very well may start Tamiflu on this patient, the answer would be to actually order the EKG, BNP, troponin, and chest x-ray. In this patient, I would also get an echo at the same time because this patient has a known severe cardiac condition, which is aortic stenosis, and you don't know the status of this valve, right? So if she's already got a red flag symptom and that, I'm still going to need to know what the status of her valve is because of the fact that she's already presenting with these other symptoms. So I would start with that. The reason you don't start with IV fluids and Tamiflu is that these patients can be very fluid sensitive. And so starting fluids is actually incorrect because you can actually make this patient worse by giving her fluids if she's already potentially fluid overloaded. So be very careful, because if you give this patient IV fluids, you can actually push this patient over into an arrhythmia and into a cardiac event. And if these patients have a cardiac event, sometimes they cannot be resuscitated once they go into a cardiac event. So that's why A is wrong. You don't want to start the Tamiflu and give this patient IV fluids. And again, giving them Tamiflu and then sending them home, that's, again, when you have somebody with these mild symptoms, even though she has the flu, realize she's going to be working overtime. Her heart rate's going to be up. All these things, those things in a patient with aortic stenosis can put her heart and her valve under strain and actually precipitate a cardiac event. So you want to make sure that you are evaluating whether or not you think this patient could have a cardiac event right now, and then treat her appropriately. And again, do not start fluids on these patients immediately. I would actually withhold fluids right now until I'm sure of what her echo and labs are before I do that. And so now we're at the final end of this. Thank you guys for hanging in here with me. Remember to ask your patients about recent pregnancy, because some of them won't just give you this information. Cardiovascular disease, maternal death may be prevented with earlier recognition, referral, diagnosis, and treatment. That's why we're talking about screening today. And we desperately need our family medicine providers, you guys, to help us detect and treat heart disease and hopefully improve pregnancy outcomes and improve future cardiovascular health. And just remember to screen for cardiac events in pregnancy and up to 1 year postpartum. Thank you so much for sticking around today. Thank you for listening to this presentation. And please, please feel free to reach out to me with any questions or concerns or anything, or any collaborations. You can contact me at teresa.byrd, B-Y-R-D, Teresa.byrd at wellstar.org. Again, Teresa.byrd, B-Y-R-D at wellstar.org. Thank you so much for tuning in today. Thank you.